The opinions expressed by the host and guests in this show are not necessarily the views of Children's Health Defense.
Good morning, everyone. It's March 19th, 2025. We have some breaking news for you. I'm going to bring on our Brian Hooker, our Chief Scientific Officer, Dr. Pierre Kory, and Dr. Ben Edwards. Good morning, everybody, and thank you for being here. To our viewers, Children's Health Defense has been given permission to look at the medical records of the 6-year-old girl that died with measles, and they are now going to be sharing with you, as the family have asked, specifically to share and report, to warn other parents and other people about some of the things that have been going on. So handing straight over to you, Brian.
Thank you, Polly. Well, we know that the little girl that passed away, she actually was recovering from the measles. Her measles rash was fading. She had seen a pediatrician beforehand who gave her cough syrup and recommended Tylenol. But because she was having, after the measles rash was fading, she was having problems with a cough and with breathing, then the parents took her into the ER. They took her into the ER on a Saturday night and saw a resident there and who gave the little girl antibiotics. About 2.5 days later, she was not progressing. She was getting worse, and she ended up in ICU. And then about 36 hours later, then she died. So, just that's sort of the threadbare portion of the case. We want to bring on Dr. Pierre Kory. Dr. Kory is an expert in emergent care as well as pulmonology. Dr. Kory, you've had a chance to look at the medical records. What's your assessment?
Yeah, so I've done medical case reviews for malpractice lawyers for a good part of my career. And this case was tragic and really had nothing, I shouldn't say nothing to do with measles, but she did not die of measles by any stretch of the imagination. In fact, she died of a pneumonia, but it gets worse than that because she didn't really die of the pneumonia. She died of a medical error. And that error was a completely inappropriate antibiotic. It was an insufficient antibiotic. And, in reviewing cases, I've reviewed cases of pneumonias that went unrecognized or mistreated. And normally when you review a case, it's difficult to pinpoint blame unless you know exactly what the organism was. And in this case, we did know what the organism was. She died of mycoplasma. And the tragedy is that mycoplasma is an extremely common, what we call community-acquired organism. This is very commonly circulating in the community. It causes pneumonias. And when you admit someone to the hospital for pneumonia, what you need to do is you treat what's called empirically, meaning you put them on antibiotics that you think will cover the most common organism. And that's why this case is absolutely enraging. It's infuriating because she died because she got an inappropriate antibiotic. The most common antibiotics that we use, it's in every guideline, infectious disease, pulmonary, every guideline in the country tells you that for a hospitalized child or adult who gets admitted to the hospital, you put them on 2 antibiotics. One is from a category called beta-lactams, which is like penicillin, cephalosporins. And they got that part correct. They put her on something called ceftriaxone, which was excellent. But you always need to pair it with an antibiotic from a different category, which is called a macrolide or a quinolone. And they did neither of those things. They didn't put her on the most common, which is azithromycin. And the tragedy is that mycoplasma is an organism that doesn't have a cell wall. Penicillins and cephalosporins work by disrupting the organism's cell wall. But if you don't have a cell wall, you need a different mechanistic antibiotic, which is azithromycin, which interrupts the protein synthesis and messes with the formation of proteins in the ribosome. But I don't want to get too geeky with that. I mean, this is like medicine 101. You put them on 2 antibiotics to cover all the possibilities. And unfortunately, this case gets a lot worse than that. Because not only did they use an inappropriate antibiotic, so they used ceftriaxone, which was correct, they added something called vancomycin to it, which works similarly, and it covers very drug-resistant organisms like MRSA. There's no reason to think that this child would come in with MRSA from the community, from a Mennonite community. She's not coming from a facility where a lot of antibiotics are used. So it was a really, it's a grievous error. And it's an error which led to her death. And, so when I say it gets worse, she's in the hospital deteriorating. And, one of the fundamental teaching points that I've made throughout my career to my residents, to my fellows, to my students, is I always tell them, if what you're doing is not working, change what you're doing. And although this child was declining, they never changed what they were doing until the test came back for mycoplasma. And this is where it gets really troubling, because as an ICU doctor, when I need a new antibiotic, I identify an organism in someone who's critically ill. When I order that antibiotic has standards. It should arrive within at least 2 hours. And from my review of the records, the antibiotic was ordered 11 p.m., or approximately 11 p.m. And as far as I can tell, it was not administered until 9 a.m. the next morning. It was actually written to start the next day. And so not only did you have several days delay of decline without the appropriate antibiotic, but then when they realized that they were missing the appropriate antibiotic, it took them, as far as I can tell, 10 hours to administer it. And by that time, she was already on a ventilator, and approximately 24 hours later, actually less than 24 hours later, she died. And she died rather catastrophically. As she was declining, she was in a state of what's called shock, and she needed medicines to maintain her blood pressure. And suddenly her blood pressures crashed and she arrested. And that kind of suddenness in an infection suggests some other cardiac event. And in a child like that, with that amount of inflammation, infection, and disturbances in the bloodstream, I can only surmise that she died of a catastrophic pulmonary embolus. But by the time that happened, there's not a lot you can do. There's some stuff you can do. You can use clot busting medications. And I've done that in the middle of cardiac arrest before. And I've had a couple of rescues, but it's not a high probability that you do that. But, rather than focusing on that final event that caused her death, it really was all of the missteps that occurred. And so this, like you said, Brian, she was recovering from measles. Getting a secondary bacterial pneumonia, and let me give the hospital some credit. They correctly diagnosed her. They very quickly on admission realized that she was coming in with a secondary bacterial pneumonia. And I think that was an absolutely correct diagnosis. The treatment was absolutely incorrect. And when I say it has little to do with measles, secondary bacterial pneumonias can happen after any viral infection. And so, this is not, we're all, everyone's grandstanding and all this outrage over this measles. You see the media is going nuts about how everyone needs to get vaccinated. I would tell you just simple, straightforward, correct medical care. We've been treating pneumonias for decades with antibiotics, and this was just a tragic error of an insufficient and incorrect antibiotic regimen on admission.
Okay, so just breaking this down, she enters the hospital at the emergency room with community-acquired pneumonia. She gets basically ceftriaxone and vancomycin, both that attack the cell wall on a bacteria that we find out later that does not have a cell wall, so there's nothing to attack. When they now, and standard of care would have been to give ceftriaxone and azithromycin, right? That was
Correct.
the first major error, correct?
Correct.
Okay.
Absolutely correct.
And then as she was getting progressively worse, and they finally got the lab order back that it was a mycoplasma that does not have a cell wall, they delayed it 10 hours before she actually got azithromycin. And that's correct, too.
That's correct. And I should add one more feature of that. So the records show that she arrived around, actually, it was in the middle of the night. It was a little after noon
Right.
on, I think it was the 22nd.
Correct.
And the mycoplasma came back in the middle of the night on the 24th. So you have like over 48 hours before that test was positive. And then the antibiotic is administered the next day. So you almost have 3 full days of a declining, seriously declining medical status with no real changes being done into her treatment plan. And I would have said, even without the mycoplasma, anyone reviewing that case, if I'm taking care of someone and I'm rounding on them every day, and I see that today they're doing a little bit worse than yesterday, and then the next day they're doing a little bit worse than the day before, I'm going to review exactly what I'm doing and say, what am I missing? What am I missing? What else can I do? And that didn't
Right.
happen until a test showed up on a computer. And that's just not doctoring.
No, it doesn't look like doctoring at all. And she passed away because of medical error, because of the first error, the wrong antibiotic, and then the second error, delaying the antibiotic by 10 hours in ICU, where every second counts. Dr. Ben, you had a chance to talk directly with the family. You've talked to the parents of this little girl who passed away. What was that like? And you're also the treating physician for their other children, correct?
Yes. So Peter, the father, specifically asked me about making this public and what should he do, and he has a concern for other children. So, excuse me, his motivation is the love of his kids, other kids. He knows other kids are in the hospital right now. So that's his motivation is pure. I know this is a very potentially inflammatory subject. It's a tragic error. I do want to say, as I look through the medical records, there was some outstanding care given all along the way. And as Dr. Kory's pointed out, unfortunately, this was a big mistake, a tragic mistake, and I agree, a fatal mistake. But Peter's goal is not to inflame the situation or cause more division and more just hot rhetoric. And in fact, I was being interviewed the day his daughter died. I was in the middle of an interview. And I remember that reporter grabbing his phone, and the alert just came from the news alert, just announced first measles death. There was almost a giddiness in his response. It was disgusting, actually. And I want people to know Peter doesn't want this information to be used on the other side in the same almost giddiness kind of way of, aha, we got you. He simply wants the truth to be told so that other kids who potentially could go down the same path as his daughter won't have to. He has a pure, loving heart and a motivation that's pure, and he wanted me to share that and express that, and he wanted this to be public for that very reason, not to inflame the situation, not to give one side more ammunition. He's not like that. That community's not like that. They love their neighbor, and he told me that. He said, I love my neighbor, and my neighbor's my enemy. My neighbor's the one who hurt me. My neighbor's the one who offends me. I'm going to love them. And his motivation's pure in this. So I just want to say that and get that message out so that we can maybe come to the table on this. There's potential risk of measles, complications and death. There's potential risk, complications and death from MMR. We need to have that conversation at the table, both sides, in a truthful, honest manner for the sake of these children. That's what he wants. That's what that community wants. I've asked a lot of these parents, were you vaccinated for measles? Yes, I was. That generation, many of them were, and the kids aren't. And I ask them why. 12 vaccine injured in that community. We can't ignore that anymore. We have got to come to the table and have this conversation. And that's his heart. That's my heart. I'm not, I think I'll leave it there right now. Peter just wants all the children to have the best care they can. And for my colleagues, I would just say use every tool in the toolbox to treat that patient that's in front of you today.
Right. And you, talking to the parents, you are their treating physician. How are the other children doing?
They're doing very well.
Doing very well and have recovered essentially from the measles. I know that measles is still going through the community, but it sounds like their children have recovered. Is that correct?
Correct. And we are seeing post-measles pneumonias. I've seen some other pneumonias. So I'd like my colleagues in the community to understand that and know that. It's something to be watching for and covering for with a macrolide antibiotic.
Right. And Pierre, going back to you really quick. So this this would be, textbook 101 if somebody was entering with, and you explained it beautifully, a pneumonia that they were acquired from the community, not from a hospital facility, but from the community. So this would just be sort of basic antibiotics 101. This is how you treat an yet unidentified community-acquired pneumonia.
Yes, and that's what it requires, because when a child or an adult, anyone presents to you with a pneumonia, it's impossible to know immediately what organism it is. So you have to, we say empirically treat. You could use the term guess. You have to guess what organism could be infecting this child, and so when you make that guess, you put them on. But I will tell you the guidelines. We've studied the organisms that circulate in communities, the most common ones that people come in with when they're sick. And that's why if you look up any textbook, any guide, any recommendation from the professional societies, that they're all the same. They basically recommend this kind of broad coverage, and then you narrow it down as you understand as you identify the organism. And the other part of this is that azithromycin penetrates really well into the lung tissue, and it's very effective against mycoplasma. And just knowing that, it's disturbing when I review the chart, because I'm seeing that she's missing a really critical antibiotic that would have turned her around. I believe that with high confidence. This was an otherwise healthy child, as I understand, who came in with a common pneumonia, and a routine appropriate antibiotic would have, I believe, changed that trajectory from what it unfortunately and tragically became.
Thank you.
And
Dr.
could this mistake be made again? I'm sorry, go ahead, Polly.
No, I was just going to close the show, but fine, carry on.
Okay, could this mistake actually be made again?
Yes. I mean, inappropriate antibiotics, sometimes they're too narrow, and this one actually was, in a way, too broad, but it missed a certain segment of organisms. Vancomycin covers a lot of different organisms, especially drug-resistant ones, but it was inappropriate because it doesn't treat mycoplasma. And so these kind of mistakes can be made for sure. But I think, Dr. Edwards said it really well. I think we're not here to inflame, but we're just here to be accurate, deliver the facts. And really, when a medical error happens, the entire medical system and community should use those errors to learn from, to do better the next time. That's why we do quality case reviews. And that's why when these errors come out, it really should be a teaching point and a lesson to all those who treat pneumonias in the community, and so that this doesn't happen again.
Absolutely. Thank you so much.
Can I just say one thing quickly? Dr. Edwards, the mainstream media is saying that this child would be alive if she had the MMR, playing on the vaccinated. You have seen people that took the MMR and got measles down there. I saw them myself when I was with you.
Yes, I have. And that's not to say that it won't decrease, the chances, but the real question, I believe, is risk benefit. I haven't heard that conversation. The admission that there is risk, we need to really get an accurate understanding of vaccine adverse events. We need to clean up errors. I believe we need to be able to give true informed consent by having an accurate understanding of what are the risks of MMR. And that's a conversation this country needs to have.
And the parents in the interview saying categorically they would absolutely still not recommend the MMR and would not give it to their children. They would take measles. Okay. Thank you, Dr. Ben Edwards. Thank you, Dr. Pierre Kory and Brian Hooker, for coming on this morning with this breaking news. And if there's any more, you will update the public.
Absolutely.
Thank you.